So just a quick disclosure slide here. You can see some of the disclosures. I do clinical research, so I had to work with companies, and that's what you're seeing there. And some of the advisory capacities that I function in as well. So what are the learning objectives for this session? So we want to understand the nature of low-grade gliomas and also understand the current classification. How are these tumors classified? I'll give you an updated understanding of how molecular profiling has come into the field in a way that has changed the way we look at these tumors. And these molecular profiles also seem to drive the clinical course of the tumor. We'll look through some of the current treatment recommendations so you can see what is considered standard of care. We'll also look at some of the factors that may influence such choices, like how do you select a certain type of treatment and when do you select it? That's one of the questions of this session as well. And finally, we'll briefly touch on new treatment options on the horizon, and there are breakout sessions there as well with some of that being discussed, but I'll focus on the basics of how we deal with this. So just as an introduction for people who may not know the details of how a brain works. So these are the kinds of cells we see in the brain. So you can see the nerve cell, the neuron, which is the one that we use to think, feel, experience the world. And then there are supporting cells. For example, there are the astrocytes, which look like stars, hence the name Astra. And oligodendrocytes. And oligodendrocytes is oligos, few, dendros, branches. So cells with fewer branches than the astrocytes. That's how they were named. The astrocytes support the nerve cell function, you can see here, with a variety of contacts with all the cells here. The oligodendrocytes have a specific function of wrapping around the nerve fibers that are running from the nerve cell all the way to the next nerve cell or across the brain to the nerve cell on the opposite side. They encase it like this. And these encasements, basically these wrappings that you see here, help the nerve cell fire faster. And that's their function normally. So the brain has evolved into having all of these types of cells that can do the different functions. Microglia are immune cells that stay in the brain, and they are sort of, they do surveillance of the brain for any problems that are going on and then take action locally if needed, such as forming scar tissue, etc. So sometimes you have injury, those are the kinds of cells that come in to try to help seal things. But in addition, as you know, these are what are in the brain per se, but there are blood vessels that come in. And the blood vessels bring in blood supply and nutrients to the brain. And that is exchanged into this milieu of where the astrocytes and nerve cells are sitting. And that's how the nervous system gets this nourishment. And there are many vessels running through the brain, and they kind of allow these nutrients to come in and feed the normal brain. To make sure that bad things don't get in, there's a barrier, and that barrier is built around the wall of the blood vessel. And it is these cells that you see that form the shape of these tubes. The junctions of those cells are sealed with specific mechanisms and proteins and other things that are built there. So things in the blood don't inadvertently get into the brain. So that's the protection for the brain. If you think of your brain as the central processing unit of your computer, you want it to be safe from all the bad things that are going on. So that is sort of the firewall between the blood vessels, which carry all kinds of things, and the brain, which is processing information. So in the normal brain, these are the structures that are necessary for function. And we are talking about billions and billions of nerve cells and billions of these kinds of cells. We're not talking about just a few hundred cells or thousand cells. These are packed and organized in a very specific manner. So let's go switching to where do these cells come from? As we develop from when we are an embryo to a fetus to a baby, there's development going on tremendously. And there are these stem cells that you all heard about in the news many times now that are the sort of the mother cells. So they have the capacity to form these daughter cells that can go and do the jobs that the body needs. And these are stem cells that are present all through the body in the nervous system. There are the neural stem cells. And they can go one of two ways broadly. So for example, they can form these astrocyte precursor cell, the precursors to astrocytes, that then go on mature and become the astrocytes that I showed you in the picture before. Or they can go into this oligodendroglial precursor cell that can become oligodendrocytes. So normally this is the direction cells are formed. And this happens very early in our life. And then through the rest of our life, mostly neural stem cells do not divide much. Now, neural stem cells also give rise to neurons. And I didn't show that here because we are showing the supporting cells alone that are relevant to our discussion about the gliomas. It can also give rise to neurons, and that's how the neurons are formed in the brain as well. So there is a mother cell that can divide and form all of these things. Now, in gliomas, which are the most frequent type of primary brain tumors, what happens is, so the nerve cell tumors are very rare, glial cell tumors are very common. So if you look at that, what you see is defects happen. So either the precursor cell or the stem cell itself can have defects of some kind. These can be mutations, which are alterations in the sequence of the protein. And those mutations make those proteins either not function or they function in an abnormal way. And tumors or cancer in general is thought in the terms of proteins that can serve as accelerators and proteins that serve as brakes. So if you think of the cell in a state where the brake's on, nothing's dividing, the cell is kind of existing and doing its job, and somewhere there is a defect introduced, which is that brake gets defective, then that protein which is telling the cell not to divide is now somehow not functioning, and the cell begins to divide in an abnormal manner. But it does that now, everything is a little strange because it's not supposed to be dividing. Then other alterations creep in and the structure begins to get unstable. Similarly, if the accelerators go on, which means a protein that is supposed to cause division begins to be produced in excess, or it's produced in a form which acts faster than the normal protein. Either way, that those factors can now tell the cell to divide faster, and it's not really doing all the checks and balances to make sure that the cell's dividing correctly. So you simply have a lumbering sort of growth of cells that is becoming potentially progressively abnormal. In time, that forms a tumor that we call a glioma. Now, if it goes from the oligodendrocyte precursor cell area, or if it goes from the astrocytic precursor cell area, it forms those respective tumors that we call low-grade oligodendroglioma or low-grade astrocytoma. And I'll get back into some of the details of that in a second. But then what can happen is over time, these can acquire further mutations and alterations that can drive them into a high-grade astrocytoma. And some of those become progressively resistant. And that is the progression that we often see with these types of tumors. So with that in mind, let me switch to just give you a sense of how many of these tumors are. So the vast majority of gliomas that we see in humans are glioblastomas, which are the grade 4 highly aggressive tumors. So these tumors directly form from these precursor cells that I was mentioning without going through any intermediate step. So somebody who 3 months ago had a normal scan can have a problem, a seizure, they have a scan, now they find a glioblastoma, and that can happen that fast. This is not the type of tumor we're going to talk about today. There are other sessions dealing with that. We are talking about these lower grade tumors here, the oligodendrogliomas and the astrocytomas. And these are relatively infrequent if you look at this. And you can see there are some anaplastic astrocytomas, the grade 3 version. There are anaplastic oligodendrogliomas, which has a grade 3 version of the oligo. And there are a smattering of other types of gliomas as well. So understanding that these are relatively rare, that's one of the reasons why treatment plans and how to manage these tumors has not been very easy to do, because you had to wait a long time to get enough people on a study to even compare and say, okay, this is a better treatment than the next one. So these studies on low-grade gliomas have been very slow in building up because it takes sometimes decades to do those studies. I just wanted you to get a sense of some of the data that we have that I'll be showing you that has come over many years. So in the previous classification of gliomas, it was a fairly simple classification based on the appearance of the tumor. So if you take out the tumor through surgery and send it to the pathologist, they make slides, they stain the slides, they look at it under the microscope, and then they say, what kind of tumor is it? And this is the kind of classification they used to do. And they had a number of features they looked under the microscope to find. And based on those features, they would say, oh, this looks more like an astrocyte, so this is an astrocytoma. This looks more like an oligodendrocyte, so this is an oligodendroglioma. Sometimes it's a mix of the two. And it can be a grade 2, which has certain features. And if it has more high-grade features, it becomes a grade 3. So this is sort of the range of tumors that we'll be discussing today. And of course, the glioblastomas, as I mentioned, are a completely different type of appearance under the microscope. So this used to be the classification. And this was challenging because there was a study done where they gave experts, four of the leading experts in the United States, slides of these tumors and said, can you tell us what these are? And as it turned out, some of the tumors they were able to identify reasonably well. But some of these types of tumors, some people called it an astrocytoma, some people called it an oligodendroglioma. So even the experts had difficulty judging what those tumors are. So eventually we realized that this kind of a classification, looking at visual parts, is not as good. But I'll still walk you through what we used to do, so you get a sense of where we are coming from and then go to the next step. So start with the astrocytoma grade 2, which is one of the tumors I showed you. So this one usually happens in the 20s to 40s, but I have seen people in their 60s having this as well. You can see pediatric patients having this. And the pediatric tumors, which we are not discussing here at this time, are somewhat different because they happen in a developmental stage that's a little different from these. But they do come, as I mentioned, from the astrocytic precursor type of cells, often present with seizures or headaches. Seizures, surprisingly, are more common in low-grade gliomas than in high-grade gliomas because the tumors grow slowly and irritate the brain. There are secretions and other things that cause that. Headaches can happen. Occasionally, there are focal deaths. Some people may get weakness or speech problems that may happen. Sometimes they're incidentally found. Somebody has a motor vehicle accident, falls off a thing, hits their head, they get a scan, unrelated to the fall. You find a spot. Now you have to kind of say, what is that? And then and you may discover that's a glioma. These are considered infiltrative tumors, which means they start in a place and then they can go into the brain. And that infiltration, sort of the fingers and the roots, are one of the characteristics of these types of tumors. Many people that have gone through this know when you get through an MRI scan, you get up half of the way, you get the dye that goes into your vein, and that goes throughout your body, including your brain. For these tumors, more than 90% of this will not leak the dye. So when you see a tumor like this, there's very little brightness when the dye is given. So this is not a dye scan, but if you do the dye scan and check again, you may not see any brightness throughout the area of that. And that is one thing that tells us perhaps this is a lower grade glioma. When you actually take it out and then look at this, you will see markers of these glial cells, particularly the astrocytic type of cells. There are a few dividing cells typically and no other aggressive features for the lower grade gliomas compared to the grade 3s or the grade 4s. So this is sort of the appearance of the tumor under a microscope. A gemistocytic subtype exists, which looks something like this, more pink and rounder cells compared to this, and that is considered to be a little more aggressive than the typical low-grade glioma. So when you see that, people pay a little more attention in terms of treatment and follow-up to keep a closer follow-up. So this is the astrocytoma. How about the oligodendroglioma? Here you can see, even though this is also an infiltrative tumor, it has roots going in. It looks a little more circumscribed on this scan. And this also is very similar, present from the oligodendroglial precursors and similar kind of presentations. The appearance under the microscope is very distinctive. You can see this fried egg appearance. You see this chicken wire vasculature. This were the ways that the pathologists in the previous, this is what I was mentioning. Pathologists would look at this, look for these kinds of features and say, okay, this is an oligodendroglioma, whereas the other one that you saw was an astrocytoma. Again, infiltrative. Again, most of these do not take up the dye. They often have a little more sharper edge here, but they still have roots that go out. Sometimes they show calcium deposits or cysts or bleeds. So these features all help us say, okay, this is an oligodendroglioma. And as I mentioned, sometimes there are features of both, and that was the challenge we are facing. So such visual analysis by a human being is not sufficient, we found out, to provide real insights into how this tumor may behave and the outcomes of such low-grade tumors. So that's where the molecular alterations, the molecular profiling became very important, and that's where we have changed the way we look at these tumors in a large way, and that can help us better tell what the course of the tumor is and what the clinical outcomes. That then leads us to the question of, okay, if we can have such markers discovered, can we say upfront when we see somebody, when we have a marker like this, will they do better with a certain treatment or not? And that's called a predictive marker, which means if you have this and you get the treatment, you will do better. So those are the type of questions that became possible. And one of the first ones, you can see when this happened, 1998, was when Dr. Cairncross and his team in Canada recognized that these grade 3 oligodendrogliomas were responding to chemotherapy, that the grade 3 astrocytomas or the grade 2 astrocytomas were not doing. So they said, okay, this is interesting because here is a chemosensitive tumor. So they dug in deeper and found out, do all the oligodendrogliomas do this, or is it specific to certain types of oligodendrogliomas? And as they looked deeper, they realized that it was not all the oligodendrogliomas. When you do a chromosomal map of these tumor cells, this is how a human chromosomal map would look. You can see the 22 pairs of chromosomes and the XY that make us male or female. In these tumors, what was noticed was there was a loss of the upper arm of chromosome 1 and the lower arm of chromosome 19 here. So the short arm is called 1p, the long arm is called q, so this is 19q. So you can now, even then, you could actually develop DNA strands that could actually be colored, and they could stick to these arms. So you could throw these things into the cell and see if they stick. So if there was nothing to stick to, that signal would not show up. So in this case, there's a green for the short arm of chromosome 1, red for the chromosome 1 short arm and green for the long arm. So when you do this study, you can see that the long arm is showing up with a green that tells us the chromosome is there. For the short arm, the second dot is not there. So that means one of those chromosomes lost that arm. And you can see the same for the 19 as well. So you are now able to just toss these things and then find out. And this is important because this is a fairly standard pathology test. So the world over, if somebody wants to do this, whether it's in a country which does not have advanced medical facilities or so, if you have a pathologist with some of these probes, these are things that they are able to do. So what was realized was if you had these deletions, this was one of the things that showed how people do. So here is a curve. And if you start with 100 people and then watch them over time, and these are the number of years, when we lose people, the curve drops. So the higher the curve, the better it is. So in this case, you can see people with the anaplastic oligodendrogliomas that had the loss of 1p and 19q actually did way better than people who did not have that loss. So this is one of the indicators to say, okay, so this is a marker that can tell us how people are going to do over time. So very, very important sort of finding. From then, it has been a huge effort of trying to find many, many types of markers and thus expanding on a daily basis. So here, I want to walk you now to switch to a clinical paradigm and say, okay, so with this information, let's go into a patient walking into the clinic and how do we make these decisions? So let's take the example of this particular person who had a fall. They took them to an MRI scanner. The fall did not cause any problems, but on the MRI scan, there was a spot seen. It's a small spot. It didn't brighten up with the dye. It looks very tiny. It's not doing anything. It's not pressing or pushing on things. So what is this? Is this a tumor? Is this scar? Is this some sort of developmental area that the person has been born with and may live with for the rest of life? There's no way to tell by just looking at the picture. So the question is now, what do we do? Should we operate on this person? Should we go in and try to take this out and look? But will we be operating on scar tissue and thus exposing the person to the dangers of a surgery? So those are the challenges. So it's not uncommon if you see very small spots like this to observe for a little while and see what happens. So if you over various scans over periods of time, if you see it's unchanging, then you may opt to wait and watch and not do anything. So these are, you have to be very careful about what kind of patients you pick here. It has to be, you have to also see what else may be going on. Is this an MS block, which multiple sclerosis? Is this some sort of other neurologic disorder, unrelated tumors? Those workups must all be done. So spinal fluid taps and follow-ups and other things. But going in to think of this as a tumor right off the bat may not be necessarily the first approach. But if you continue following it up and you see that it grows, obviously, then any slight growth, and it doesn't have to be this degree of growth, you would say, okay, this is growing. This is not a static thing. We have to find out. So this is the time when surgery may become important. Now, there are surgeons that will go in and take this out, and there are a lot of oncologists and surgeons that will wait till there is a change. It all depends on the appearance of the lesion, and I'll show that to you in just a second. So what happens here is, if there are gliomas, we have noticed that if you follow these along, they can go up to 35 to 80 months before they grow. So it may well be that some of these tumors are growing over a long period of time and we just don't know that. So sometimes it is true that we may be catching these very early when we search such scans, but the fact that we're able to look at them and have MRI surveillance is sort of the buffer, sort of the insurance for safety. So if there's a change, obviously take the person to surgery, get information, and then make decisions. If it was a tumor, there was also data here from studies that taking out all of the things that you can see here, everything can be removed. That generally ends up with people doing better. And again, higher the curve, better the outcome, versus if you're not able to take all of that. Similarly, if you have an oligodendroglioma, generally your prognosis is better than if you have an astrocytoma, but that is not a hard and fast rule. Some people you can see who have astrocytomas do well. Some people with oligodendrogliomas don't do as well. So it is not like if you have one, you have a certain outcome. In general, on the average, that's the kind of outcome that you're seeing. Now let's change that to seeing something like this. So let's say we have a scan after somebody falls and there is no symptom, it's an asymptomatic person, but this is what we see. Now this is a mass. So this is not like the previous scan. Here, we would not hesitate to say, we need to find out what this is. This is a growth that's causing some pressure effects, and I think we need to find out what that is. Now, many people by this time may actually be symptomatic, so they come in with a seizure and you may see the same thing. And if the question is, should we operate? The answer is yes. And what kind of surgeries may result? Depending on the location of the tumor. Sometimes the surgeon is able to go and take it all out, whatever we are seeing here. Now, we do know there are fingers of the tumor that go beyond this, but the objective is to be safe. So the idea is to take out everything that you can see on a scan, as you can see here. The surgeon has removed nearly all of these tumor that they could see. But let's say the speech center is right here. So removing this whole thing in this patient may mean that after they come out of the surgery, they may not be able to speak properly, ever, because you're taking out the speech. So in this case, you will often map these things with functional MRI scans and other sort of things. There are awake craniotomies that people do, which is basically during the surgery, they wake up the person and say, come on, say these things. And they go through tests and you can see if anything is being affected in a certain part of the brain. And then they put them back to sleep and then go back to surgery to try to remove as much as possible. So sometimes because of these functional areas being very close, you cannot remove everything. And then there's a partial resection that may need to be done. After that, we will get a diagnosis, and I'm giving you the possible diagnosis here. Then the question comes, okay, so this is a person who's had either this or this. What do we do? Do we observe this person? Do we give radiation therapy? Do we do radiation plus chemotherapy? So these were the questions that have been plaguing us in the field in terms of what is the best thing to do. So people used to choose based on whatever their bias was. For example, if you're 22 years old and you have a tumor like this, if I give you radiation and chemo, I might give you a lot of side effects. You're young, so I don't want to trouble you with all these side effects. So I'd rather wait. And if it grows, then try to give you the treatment. Or other people would say, no, I don't want you to wait, because if you wait and it grows and I have more trouble taking it out, let's go ahead and do the treatment now to stop it from growing. But you need to know that there may be side effects from that treatment. So this is the kind of discussion that used to take. So studies were done. For example, there was a study of radiation therapy in low-grade gliomas. The question was, how much do we give? Do we give a lot of radiation? Is it high dose? Or can it be a lower dose? So in this study, when high and low dose were compared, you can see the curves are similar, which means the low dose did as well as the high dose. So people said, okay, we don't need to give high dose. We can get away with lower dose. Another study here went even lower to 45 gray. These are the units of radiation therapy. So from 64 to 50 here, and from 59 to 60 to 45 gray. And the 45 gray also gave the same kind of outcome, saying that you could grow as low as 45 gray and still be able to get the same benefit as one of the higher doses. So this said, how much radiation should we give? This is the type of radiation. So when should we give this radiation? Should we give it early, when the time of diagnosis, right after we give the take out the tumor? Or should we give it watching for some more time, and then we wait, and then when the tumor grows, then give the radiation therapy? And what was found in this study was, whether you gave it right after or later, that the survival was similar. But there was a difference, and that was in the group that got early radiation, the progression was later. The tumor grew later because it was under control for a longer period of time. People that did not get the early radiation therapy, that tumor grew back earlier. So there can be an impact on quality of life because when the tumor grows back earlier, there may be symptoms and other things that happen, but overall survival was not different. So the trade-off here is if you say, okay, let's go with early because we can stop the tumor from growing for a while, but then you may get problems with memory or cognitive function from the radiation therapy, and that may be the impact of this. So this has to be balanced. It is not for a survival benefit that you would necessarily choose this. So this is where we were again in the old list of 2005. So at that point, when we looked at all the things, so low versus high in these two studies, there was no difference. You could get away with low. Early versus late, there was no difference. You could do it early or late with the same outcome. So this is where we were in the field. The progression-free survival, which is the time it takes for the tumor to grow back, not the survival itself, was better if you gave the higher dose or if you gave the earlier radiation. One of the most important things that we found from all this was we discovered that there was a high risk and a low risk category. The high risk people were people who are older than 40 years of age, whose tumors were larger, whose tumors crossed the midline, who had weakness or numbness or something else going on, or whose tumors were astrocytic in nature. This was from one of these studies. And the other study here showed that if, again, age over 40, doesn't matter if you took it all out or took only a part of it out, these people, or age below 40, if you couldn't take it all out. These became the high risk, and the low risk where if you're less than 40 years of age and all the tumor was taken out of the surgery. So it helps us identify these two groups, low risk, low grade, and high risk, low grade, which was very important because that led us to the next set of studies. So here's the tumor again. So as I mentioned here, you have a person who's less than 40 years of age. The tumor has been taken out entirely. This would be considered a low risk, low grade glioma. And these people have been watched because treating these people early does not seem to have the benefit without toxicity. They have more chances of toxicity, and their benefit is low because they can stay like this for a long time. And eventually they will progress. So we have to keep watching, but this may be a long period of quietness before this happens. So it's a matter of preventing toxicity by giving treatment too early. That's the strategy. So low risk, low grades, surveillance was one of the thoughts here. But if it's high risk, that's age over 40, even if you took it all out or partially, or any age above 18 years of age, if it's a partial resection, this was considered high risk. In this case, the question was, now we can't wait. What do we do? Do we do radiation alone or do we do radiation plus chemotherapy? And you saw some of the data on the radiation alone. Now the question is, should we add the chemo to get better benefit? Because waiting and watching is not good for this group. So the study was done that actually looked at this. So the low risk people were put in the observation category, just like I mentioned. The high risk people were randomized either to get radiation alone, here, or radiation followed by this chemotherapy called PCV, that's procarbazine, CCNU, and vincristine, 3 different types of chemotherapies. The idea is to attack the tumor from different directions. As you can see, about 125 patients on either group were enrolled, and then this was looked at. So again, remember, age less than 40 is the observation arm, and age more than 40 in the other group, or anybody over 18 with partial resections come into the high risk group. So the initial results came out in 2012, and then they continued to follow up, and the later results came out somewhat later. So here is the progression-free survival. How long did it take the tumor to grow back? Overall survival, how long did the person survive? So in the radiation plus PCV, the chemotherapy arm, clearly you can see the outcome was the progression-free survival was better compared to radiation therapy. And that was 4 years for these tumors to grow back on the average to 10 plus years. So clearly great protection for regrowth of tumor. When you looked at the overall survival, certainly the radiation plus PCV arm seemed to be doing better. But at this time, it was not by that much. Here it looked like almost a doubling of survival here. So this was the final result, and it was clear that if you gave radiation plus PCV compared to radiation alone, you could actually, on the average, double the survival from, if you take the 50% line, from about here to over there. So a significant increase you can see. And you can see at 10 years or 5 years, the survival of people, there's significantly more people in the chemotherapy arm. So this result was really important because this is how we define the new standard of care. And the idea was that if you were in this group, high-risk group, then there is a benefit of addition of chemotherapy. So, and these were the results that we just talked about, the progression-free survival as well. So PCV was a chemotherapy that's been used for a long time. It was one of the ones that Dr. Cairncross used for the oligodendroglioma group. So were other chemotherapies beneficial? So other things were looked at. For example, just the CCNU, which is one of those chemotherapies, or temozolomide, which is a new therapy that came out about 15 years ago or so. And these were other trials that were done. In this one, giving CCNU, there was no clear benefit. The temozolomide, there was benefit, but there was no comparator arm, so there was nothing to compare it to. They were just comparing it with historical controls, which means previous trials. So the result was not clear as to whether this was just in that study or was it truly a difference. You saw the previous studies where they put one and the other and then compared at the same time. There was no comparison arm in this particular trial. So although there was an indicator that there may be some help, it was not clear. The big change came when we discovered this particular mutation. It's called IDH mutation. It can happen in other tumors. If you have leukemias, it is actually an unfavorable type of mutation. The leukemias are very aggressive when you have IDH mutations. Gliomas, generally, they happen in the lower grade tumors. And as you can see here, it's the grade 2s and the grade 3s that have the maximum number of these mutations. They hardly happen in the grade 4s and other types of tumors. And there are specific kinds of mutations that you can actually detect using an antibody on the slide. So what did that do? That helped us completely rethink the way this is classified. So remember the visual thing of looking at slides, but here you can see, you start off by saying, is this IDH mutant? And if it is, then you look to see, I told you about the co-deletion of the 1p19q. And if you have that, then it's called an oligodendroglioma. So an IDH mutant 1p19q co-deleted tumor is called an oligodendroglioma nowadays. Similarly, if the 1p19q is not lost, the chromosomal loss is not there, then it will be called an astrocytoma. And again, the IDH mutant, there are some other features, you can call those astrocytomas. So now we know there's a divide here, whereas the IDH mutant tumors and IDH wild type tumors. So IDH is the protein, the mutation is the alteration in its sequence, and the low-grade gliomas, as I showed you, have the majority of those. These tumors, regardless of how they look under the microscope. So sometimes you have tumors that look like low-grade on the scan, that look like low-grade under the pathology, but when you do this study, you find out that the mutation is not there. They behave like the grade 4s, so they are treated in a different way. So this is the big divide here for the lower grades and the higher grade or the more aggressive types of tumors. Within this, it was also clear that if you talk about the low grade, which does not have aggressive features, this is the usual pattern. But there are some things, for example, so this is the IDH mutation I talked about, and these are the 1p19q to identify the oligo and the astro. But these things, in addition to these, if you saw these features, that puts you into a higher grade category because those tumors grow faster. So now you can see how looking at not the slide, but actually looking at all these molecular markers, we are able to say which will behave more like a grade 4, which will behave like a grade 3 or a grade 2. And that's been a big, big change. This led to an entire classification system. You can see grade 2s and grade 3s and grade 4s with all the types of tumors. So it is exciting to see all of these things being put in where they belong so that we could actually help the patients better, select the treatments better, but it's still a long list here. You can see it's a complicated list. So in 2021, that was simplified into either astrocytomas IDH mutant, oligodendrogliomas IDH mutant, and glioblastomas, which are IDH wild type. So if you have normal IDH versus the mutant IDH. So now we use these three categories, simplifying this. So you will often see in the diagnosis astrocytoma IDH mutant WHO grade 2 as the diagnosis. This is a little confusing because if you are diagnosed before 2016, you will see an old name there. And now when somebody talks about it, they'll talk using the new name. And some people have asked me, did my tumor change? What happened here? And we have to explain like, no, the tumor is still the same as it was. We just have changed the way we name these tumors. And sometimes that does recategorize some of these tumors. So some of these which we used to call a different name now come into this, and that has to be taken into account when we decide on treatments as well. So I wanted to tell you about how the classifications happen. So what does this molecular subtype tell us? As I mentioned, now we call this grade 2 oligos with mutation 1p19q co-deletion, or Astros by this name. And if you look at the outcomes, you can see how we are able to now tease out the differences. So with the IDH mutant 1p19q co-deleted, survival curves are far better than the ones for astrocytomas that are 1p19q intact. And certainly that is much better than the IDH wild type, which is in the glioblastoma, the grade 4 type of range. Even so, there are long-term survivors. So the fact that you have this or this doesn't necessarily mean anything individually. You could be here living a long time. So that is the thing that we have to keep an eye on. So I mentioned to you about some of the other categories. So the treatment also does this. For example, radiation plus PCV in this setup seems to do better in these particular types also. So we know that not only are the markers good for telling us how the tumors do, they also tell us how the treatments work. So there is a study now going on that's called the CODEL study that is looking further to see, instead of the PCV, can we use the temozolomide? That's because temozolomide is a little easier to take, and that study is ongoing. We hope to get the results from it.
And I'm
We're
sorry,
also getting,
Doctor, I wanted to make sure that you knew, I think the room is going to close in just a few seconds.
okay, so I will just point out that many mutations are being identified, that treatments are also being developed for this. So we have many new things that are coming as well. And I want to leave you with that thought